Hi, everybody. Again, I want to let you know my brother from another mother, my little brother, Gideon's not here today. He took a day off. So you have me, and I am going to be leading Aesthetic, our wonderful AI Live today. And going to be sharing with you something that's kind of deep to my heart and something that probably scared me as much as anything in my life. And I'm going to kind of talk later about my incident with Nitrous and kind of really bring it to you from the perspective of the rabbit holes I went down and how I wanted to know why what happened. And so I'll be going through that, give you a little presentation on that tonight. But first, I want to go through a little bit of housekeeping. One thing is, if you guys, I have a little section over here on another TV that I can see where if you guys have some comments, please write in some comments, ask me some questions. We've got time to kind of sit and talk tonight since I'm by myself. But please just go ahead and chit chat in the chat on here, and I can look over and answer it for you, and we can kind of make this a little bit more personal. And I like that when I'm with you and you're with me, and we can just kind of chit chat together. So it's not just me talking this whole time. I want to go through a little bit of housekeeping. A couple things, quick announcements. We have on January 20th, we have a webinar that's a cannula webinar. Now, this again is something that is near and dear to my heart. I am a cannula lover. Not that I don't use needles some of the time, but cannulas I truly believe can be so much safer in the hands of somebody who is gentle and thoughtful. In the hands of somebody who pops through things and is forceful in any way, they can be just as dangerous as a needle. So this cannula webinar is going to help to kind of give you insight into cannulas. What are they? How do we use them? When do we use them? Where do they work best? How are they different from needles? So it's going to answer a lot of questions for you. And I hope that it will kind of open your eyes. If you do want to try some cannulas, that you try some. Just know it's a long learning curve. It's not that you're going to be good right off the bat. Just take your time and inject small amounts at first. You can always, it's easier to add than to dissolve, rule number one. But it will help you kind of get a little bit more confident with using cannulas, but give yourself leeway, give yourself patience, because it's a long learning curve. We are going to be having some webinars coming up. We have a webinar that I'm doing with Professor Sebastian Cotofana. It is going to be January 22nd, and it's going to be all about biostimulators. Now, this is going to be a combination. I don't miss the webinars we are doing, you guys. So this first one on biostimulators, again, January 22nd at 6 p.m. Put this on your calendar. Professor Cotofana and I are going to be going through and talking about biostimulators from two different aspects. You're going to get information generally on how they work. You're going to look at cadaver dissection and look at the planes of tissue that they work the best in. And his dissections are bar none the best ones you've ever seen. And I'm sure he's going to be showing us things that we didn't dream were under the skin. So he's going to be dissecting. I'm also going to be injecting a patient and showing the different planes of tissue I inject in and how to know you're in the right plane. So those are going to be live webinars, so you can also type in your questions and talk to us during those webinars and or afterwards. And I think it's going to be really, really educational. So put this down in your calendar for January 22nd at 6 p.m. California time, Pacific time, and join us for that. You can sign up for that now. Another thing is we have coming up January 24th, I think there might be room left, and that is our Foundations of Advanced Aesthetics class. Now this is our flagship injectable course, the Foundations of Advanced Aesthetics. This is pretty much for everybody, but you might get a little bit more out of it if you've already had some of our basic courses, and I'll tell you about those in a minute. But the Foundations for Advanced Aesthetics is something to help you learn as much as you can. You get about a 12-hour didactic that you need to watch at home and answer some questions before you even come here. So you will have this didactic of all these modules to go through and look at. And believe me, even if you've been injecting for 10 years, you're going to learn something. I recently had a colleague who's been injecting about 15 years, and she went through the course and she said, oh my gosh, I even missed some of the questions on the quizzes. I didn't know some of this stuff. So we all come from different foundations and different backgrounds, and it's so important that we really have a good, broad, comprehensive knowledge of what is going on with what we are doing. And we owe that to our patients, and we're going to be better injectors for it. So January 24th, that course, after you do the 12 hours of didactic approximately, you come here to Brea, California, and you have the hands-on component with one of our trainers. So it could be any of us that are here that day. We have different trainers that we skip around with, but everybody is amazing. We're the best educators ever. So it could be Gideon, myself, Janelle, Trevor, we have quite a few different instructors, but you get a great hands-on. And what's great about that is it's one-on-one. So with this class, we don't just lecture you and have you inject one toxin here or one dot of filler here. You get about 1 hour one-on-one with an instructor. So if you've already been injecting for a while and you're like, you know what, I can do cheeks, I can do chin, I just want a little help with lips, or I just want someone to kind of mentor me when I'm doing a cannula under the eye. If you need to level up in your expertise, but you just want someone there to kind of back you and be with you and help, that's what this class is for. So we can do basic, we can help you learn to inject, or we can help level you up to a higher expert level and a better knowledge level and expertise so that you will be safer and better for your patients. So this course is for everybody, but if you don't, it's not basic, but if you have been injecting, come level up and we will be with you to mentor you all along the way. So that's, again, going to be January 24th. That's in Brea, California. And I think there's some spots left on that. If you've already been a student here before and you just want a little bit more time on tissue, it's $500. So that will give you, if you want to come and just do like a little injection session, it's just $500 for you if you've already been here before. We also have on February 21st, we have the Foundations for Aesthetic Injectors course. Now, this is our basic entry-level course. The Foundations for Aesthetic Injectors is for anybody who is thinking about getting into aesthetics, maybe brand new in it. You've done toxins, but you haven't done fillers. You're kind of don't know how it is to push jelly through that syringe. How does it feel different than water? So this course is for you. You get didactic with it, and you get to come and you get to play with the jelly. You get to play with fillers and such, and fake toxins, but you get to play with them and inject them and kind of see how they lay down, see how smooth your lines are. You get to play with them and practice. So this is a great entry-level practice course. It's not too expensive. So those of you who are like not working in aesthetics, or you have friends who are thinking about getting into aesthetics from ICU and ER and cardiology, if you have those friends that want to get into aesthetics, let them know about this course. This is a great course to start with to see if you really want to do aesthetics. So that's February 21st, okay? Then on March 28th, we've got Fundamentals of Neurotoxin Injections. If you've already taken the Foundations for Aesthetic Injectors, you can go to the next course that is just on neuromodulators. And this one that's going to be on March 28th, it is really neuromodulator technique. How do you inject neuromodulators? Where do you inject them? Where are the muscles? How do the muscles move? How do we know where to inject? What's the outcome going to be? So this course is going to be a really good course for you. It's going to be here in Brea, California. It's going to be March 28th. That's going to be a really good one. So sign up for that now. If you have friends who have already been injecting for a little bit and they just haven't had the comprehensive education or the in-depth education, then this is a good course for them too. April 25th, Ultrasound and Aesthetics. Our last course was amazing with Candace Deary, and she is amazing at ultrasound. So April 26th, here in Brea, California, Janelle and Candace are going to be putting this course on. It is phenomenal to learn what lies beneath. I can't tell you how ultrasound has opened up my eyes, and it's helped me to visualize what's underneath, and it's taught me the respect for variance in anatomy, besides cadaver courses, which is mind-blowing in and of itself. But being able to look at real time in your patient's tissue for the vessels that could really cause a problem and hopefully avert those issues is priceless. So I use my ultrasound many times a week. I can't imagine practicing without it. If you want to get into ultrasound, if you want to learn what it's all about, this is a great course for you. You don't have to own an ultrasound. We have them here for you to use. And it is a great course, and you learn so much. So that, again, is going to be April 25th here in Brea, California. After that, we are going to be having a cadaver course called Dissecting Aesthetics. It is going to be August 15th and 16th. It's going to be a 2-day course. The first day is going to be all day, like watching cadaver dissections, listening, learning, really soaking it all in. The second day, if you opt in, is going to be hands-on dissection. So it's going to be 2 days of really, really, really good in-depth cadaver dissection and education that you won't want to miss. These classes always fill up really fast, you guys, so don't wait till May to sign up because it might be full. So again, August 15th and 16th, this is going to be here in Brea, California, Southern California. So feel free, book your flights now. So feel free to come and do that. Again, Dissecting Aesthetics, that's August 15th and 16th. I want to remind you that we have all levels of our mentorship available. We have 3 different levels of mentorship program, and each one gives you a different amount of videos you have access to and educational discounts that you get. So if you sign up for, say, our highest level, which is we call the Founders Club, that level gives you probably 450 or so videos, educational videos to watch. You will never watch them all. I don't think you'll ever watch them all, but you have such a great library of comprehensive aesthetic education, it'll blow your mind away. So that's really good. Also, you're going to have discounts on our courses. So if you sign up for that, you get discounts on the courses that I just mentioned a little bit ago. So that might be a good thing to do. Also, with the Founders Club, besides getting the videos and discounts, every 1 month, one Tuesday a month after this AI Live, we have what's called the Founders Call. So Gideon and I will hop on here and get on with our founders, and it's all Zoom. It's live, so you can see us, we can see you, and we always have a little bit of an educational component, and then we kind of chit chat, and we try to be a mentor for you. So we try to listen to some problems you've had, some adverse events that have happened, questions regarding education you might have. So we really want to connect with you and be a mentor. If you don't have somebody nearby and say you're in practice by yourself and you need someone to ask questions of. That being said, we have a terrific connection tool that's like, it's almost like a Facebook, that we have a program where you can get online with all of our mentees and you can chat and you can answer questions. You ask questions, you can answer them. You can if somebody doesn't answer them, or you can always ask us questions. The team will bring the questions to us. So it's a really good, safe area to discuss things with your colleagues that's not going to go out of that circle, out of that communication link. So it's really, really nice. And it's just something that we want to provide for you guys so that you have the mentorship and you have the support that you need in this very difficult specialty of aesthetics. It's not that hard. I think we all know that. So I'm going to move on to what's tonight's little call here. And what we're really going to bring up is how nitrous almost killed me. I'm going to kind of go through a presentation I put together after this happened to me, and I started wondering what happened, why did it happen. So I'm going to kind of go through that, and afterwards kind of we'll discuss it a little bit together. But nitrous, it really taught me that nitrous is not something to take lightly. It's, I think maybe A, don't ever not monitor your patient. B, make sure your equipment is in good working order. Make sure there's nothing wrong with it. C, make sure that your patient's in good health. There's so many different things that we want to take into account when we use something that might alter their mental state or level of consciousness at all. So let me start with this, and we are going to go through it. You know me. I've done a lot of things. Now I'm published. Yay, finally published. So in the JCAD, you'll see an article I just got published this last month on perceptual congruence. So we'll see my theory of why exactly what we do helps patients' self-esteem and self-confidence. And I believe it's something I call perceptual congruence. So in there, you guys, keep up, keep learning. I love that. Stay curious. So what is nitrous? Nitrous is N2O. It's a gas, and it is heavier than air. It is odorless and colorless. We can't see it. We can't smell it. All we feel is the effect from it, basically. We get nitrous from the soils. Natural vegetation emissions emit nitrous. So we capture those from natural degradation of vegetation, which is kind of interesting. When microorganisms break down vegetation, it becomes nitrous oxide. So that's where we get the gas. How does it work? It works by blocking the GABA receptors. Now, when we block the GABA receptors, it has a tendency to make you feel like you've had a couple shots of tequila. It has a tendency to make you just feel relaxed and like you don't care what happens. And that's why it's used so frequently in labor and delivery. It's used in dental offices, and we use it all the time in medical aesthetic and outpatient services. It's used very frequently and very safely in many, many instances. So mine is just something that happened that I had never heard of. But when I told people about this at iSpan last year, I had a nurse come up to me and let me know that she had a patient that had the same response that I had. So I know I'm not alone, and I know this can happen, and I think it makes it even more imperative on why I share this with you guys. So when we have that anti-anxiety effect, it also inhibits some of the pain signaling. And it will kind of make pain, even though it's not an anesthetic, it's in categories as an analgesic, it does put the perception of discomfort kind of in a different room. So it's like, yeah, I can still feel it, but I don't care as much about it. Is kind of how nitrous affects you. It gives you, some people laugh. I have yet to have any of my patients laugh hysterically. I haven't had that, but they term it laughing gas because some people get a little euphoria for a little bit with it. But I have yet to see a patient get giddy on it yet, but I know they do. It is one of the least potent inhaled anesthetics. It also does kind of slow down your brain and body's response to things. So I kind of equate it to a couple shots of tequila. You're just kind of feeling relaxed, like I don't care, whatever can happen. It's kind of that feeling. So what's really interesting about this is it can also cause the dizziness, the disassociation, the disorientation, and sometimes that impaired cognition. That disassociation is what we're counting on when we give it to our patients. We want them to kind of disassociate from the discomfort and put that discomfort in another room so that it's not right up in front of their face. So not only are they kind of relaxed, they know something's going on, but they just don't care. So that's kind of like why it's used in labor and delivery and dental procedures and things like that. So with anxiety, we want to help our patients reduce their anxiety. Now, what I've done before is some of my patients who have vasovagaled on me a couple times, which anxiety is, or the perception of a noxious stimuli is usually the precursor to a vasovagal because that's what stimulates that vagus nerve. So if I can reduce that anxiety that precipitates the noxious stimuli and vasovagal response, I can reduce a vasovagal episode from happening. And I do all the time. It happens perfect. If somebody's always loves to faint on me and because they get so anxious, I'll give them some nitrous and they are perfectly fine. So because it doesn't let them get so anxious. It helps people relax. They don't feel so nervous. They feel much better. Once people get it, they love to get it every time. In fact, usually what I'll do is give my tubing to the patient, and when they come back and they bring their tubing back to me, then I will give them a discount because I don't need to provide the tubing. And like I mentioned earlier, it does disassociate that pain, which is really nice. It kind of puts it into a different place. It's still there. They just don't really care about it. So in different settings, when people are in different settings, different concentrations of nitrous are used. It can be used in 100%, like in dental offices, they can use 100%. They sometimes will mix it in outpatient offices. They will mix it a 60-40, a 70-30, depending on how much sedation or anesthetic they kind of want with that patient. Most of the ones that are in our offices are usually a 50-50 mix. It's going to be 50% oxygen and 50% nitrous. Some of them are fixed. Some of the devices are fixed and they can't be adjusted. Some of the devices, the provider is able to kind of dial the nitrous up or down. That's something that is up to the provider if they want that type of a unit. It's just that those are available and that can be adjusted according to the patient's needs and the need in the setting. So what happened to me? Here we go. So I had used nitrous before and never had a problem. I had always been sitting up, getting injections. I hate needles. I'm one of those people. But I had sitting up. I have done it. I felt kind of drunk. I never had a problem ever. And this is over the last couple of years. Not very often, maybe two times, maybe over the last couple of years. And in this instance, I was face down on a treatment bed, and I was having the Ovally procedure done, which is the one that gets rid of the cellulite. We're training, and I was the model. Lucky me. So I was the model getting this cellulite treatment done. So my butt's out there, open to everybody. And Gideon, who we know and love, was doing the procedure. So it had to have tumescent numbing. So there's tumescent anesthesia. So we had a nurse practitioner there, his nurse practitioner from his other office. We had the reps there. I was laying on my stomach with my head facing forward. My medical assistant, Ashley, who I owe my life to, was sitting in front of me just because she was watching. She was just learning at that time. And we had a couple other people in the room. So I was laying on my stomach, and we had a pulse ox on my finger, but it was the throwaway. It was that little kind that we used to get during COVID that you can get for $5 on Temu. But it was just that one that goes on the finger that it turns off after, like, I think a minute. So you put it on, get the pulse ox, it just turns automatically off. Mistake number one. So he started to do tumescent numbing on one of my butt cheeks, and it stings, and I'm a wuss. So I was like, ow, ow, ow. So I took a couple breaths, and after I took a couple breaths, I could feel getting that little feeling of like, okay, I don't care as much. It doesn't hurt as much. And then I took another breath or two, and I remember looking at my medical assistant, and I remember her tapping me on the arm, and I was thinking to myself, oh, she's going to be such a good nurse. She's going to be such a good nurse. And the next thing I notice is that I'm on my back, my legs are up in the air, and I'm waking up with everybody around me. And what my medical assistant noticed was that I had the nitrous in my mouth. I had the tubing in my mouth. And she noticed that my eyes were open, but she kept tapping me, and there was no response. I was unconscious. My eyes were wide open, and I was totally unconscious. So the people treating me thought that I had vasovagaled, so they flipped me over and put my legs up. Well, you can't really vasovagal when you're flat. So they put my legs up, and nobody checked if I was breathing or had a pulse. But let me go forward here. But what happened was after about maybe 30 seconds, I started kind of coming around and waking up a little bit and saw everybody around me. And I couldn't figure out kind of what had happened. They had told me that I had vasovagaled, and I said, I couldn't have. I'm laying flat. Yeah, I wouldn't have vasovagaled. What happened? And we just couldn't figure it out. And I told my manager, don't call 911. I'm okay. Don't tell my husband. He'll kill me. And I remember just thinking in my mind, after I woke up more, I was thinking, okay, what was that? What was that? I was out. What was that? What could have happened? And my mind kept going back and forth. And so one half of my cheek was done. The other half wasn't. So Gideon said, well, do you want to just stop? I'm like, no. You got to do the other one too, because it's such a good procedure. So what I did was I wanted to pay attention to that nitrous, because I couldn't think of another reason. I don't have health problems. I couldn't think of another reason why there could have been a problem. So I went back on my tummy, and my medical assistant was there, and he started to numb the other cheek, and I took a couple breaths, and I could feel it. I could feel myself relaxing a little bit. And then I thought, okay, I'm going to take one more breath. And when I took that one more breath, I could feel myself going off that cliff. And I put the tubing down right away and turned my head and just started kind of breathing heavy to try to off-gas it. And I realized at that time that it was the nitrous. I realized that that's what put me out. And there's a question. I'm sorry, the question's over here. No, it's not the same nitrous as in drag cars. You're so cute. This is nitrous oxide, but nitrous gas does make you go fast. But no, this is a nitrous oxide of it. That's funny. So anyway, what it did was made me realize what it was. So it made me wonder what happened. Going through the differentials of what happened. Could it have been an improper gas mixture? We checked to look at the tanks. The tanks were both full. The tanks were fine. We don't have any way of measuring in our device like how much is nitrous, how much is oxygen coming out of it. We don't know. We didn't know. But could it have been something with that? Could have been a machine malfunction. Possibly, it could have been malfunction. The patient that we had done before said that she had felt kind of weird. She didn't feel right with it, so we had changed a gas tank out. And she didn't go unconscious, but she didn't feel right with it, and she had had nitrous before also from our same device. So we switched out the tank, and then it was my turn. So it was kind of a really unusual, something that we didn't expect, that we weren't expecting to kind of have happen, but it kind of sent me down a rabbit hole. So I started researching nitrous oxide, and what I found was so interesting. I found that there have been direct issues with people that have the MTHFR genetic mutation. And this is a genetic mutation that nitrous oxide impacts folate metabolism, and it doesn't let it metabolize correctly, and it doesn't let it metabolize correctly, and it will cause an increase in homocysteine levels. So it really will cause an issue with an increase in inflammation in the intravascular area. When MTHFR gene, it converts our folate to an active MTHFR, and then it can kind of converts the homocysteine to a methionine. We need that amino acid, but when it doesn't get converted, then it leads to high homocysteine levels. So that's what can really lead to problems. It also inactivates B12 in these individuals permanently. So they have a really low B12 level. And it can lead to very dangerously high, like I said, homocysteine. What I saw in the research, but there are some deaths in literature, but it's pediatrics. There was an 8-month-old that had neurodeterioration 6 days post his 80-minute long procedure of nitrous. A 4-month-old that had hypotonia and acidosis 3 weeks post 180-minute long procedure with N2O. And a 3-month-old that died because they had seizures and apnea 25 days post. So look, these are not immediately during procedures. These are after. These are homocysteine levels that are high. These are major problems that happen in some of these pediatric kids that have the MTHFR mutation. And it's right out there in literature. It was pretty easy for me to find. This is a genetic error in metabolism. This is something that I now have on the questionnaire for my patients' intake if they have an MTHFR mutation, because I won't give them nitrous if they have an MTHFR mutation. And again, I'm not talking about a certain device, you guys. I'm talking about nitrous in general. So I'm not talking about a certain device. I'm just talking about giving nitrous in general. Some of them you can adjust, some of them you can't. So I don't want someone to be upset I'm talking about a device, because I'm not. So the methylfolate reductase deficiency, like I said, leads to high homocysteine levels, drops the B12 down. These children got neurological deterioration because they couldn't synthesize their folate. And it ended up that they had neurotransmission issues, and that's why they passed away. So this is huge. And if I was a pediatrician, or if I was doing surgery on a patient, I probably would want to know if they had an MTHFR mutation. I know it's not as common, and these are probably homozygous mutations, not heterozygous, and I'll go into that in a bit. But I think that's something that I would want to know. So there's 29 MTHFR mutations in all. 10% are homozygous, and 30% are heterozygous. Now, the homozygous mutations are autosomal recessive, and those are the ones where these children, what these children had generally. They get the hypotonicity, the seizures, the psychomotor issues, the neurological issues. So these are the ones that it's only 10%, but this is huge. This can affect them very, very dramatically. 30% are heterozygous, and it causes about a 50 to 60% decrement in enzyme activity. So that means we have about a 50 to 40 to 50% enzymes that do work converting folate to methionine and help to not let our B12 drop to 0, but we only have like one kidney working and not the other, in essence. So here's the other thing that blew me away. 45 million people in America undergo anesthesia, and nitrous is a major component of that. with the increasing use of nitrous, patients with enzyme mutations are more likely to be affected because more nitrous is being used in some of these outpatient settings because more outpatient surgeries are being done. If a patient has MTHFR deficiency, we probably don't want to risk trying it on them. Let them just have the procedure without nitrous, give them lidocaine, whatever they need. And if it's an outpatient, maybe draw the lab work and see if they have the mutation. We can do it as general physical lab work. So, how much of the population has this deficiency? 40%. 40% of the population has this deficiency. So, it doesn't let you convert folate to methionine. So, what's interesting about this and what's kind of scary about this is people who have the MTHFR mutation cannot metabolize folic acid, okay? They can't break down folic acid. Now, folic acid is a chemical that is sprayed on our rice, flour, grains, pasta. It's sprayed on things. It's called enriched. If you ever see anything in the supermarket that says enriched or fortified, that means it's been sprayed with the chemical folic acid. It's sprayed with folic acid because a lack of folate, or folate is the natural vitamin, folic acid is the chemical, then the lack of it can cause neurotube lack of synthesis in a fetus. So they can have spina bifida, they can have neurological issues if there is a lack of folic acid or folate in their diet. So the government puts the chemical which takes place of folate, they put the folic acid on there, but 40% of the people cannot metabolize it. And when we can't metabolize it, what happens? Depression, bowel issues, lots of different things can happen when people don't metabolize it correctly. So what happened to me, I've used nitrous before, it wasn't a problem. I had blood work drawn by actually the amazing, brilliant physician who we have on here who does a lot of our clinical education on menopause and on IV therapies and on different types of peptides. So Dr. Salmons drew blood work on me, and I have the mutation. So that kind of made a little bit of sense to me that maybe that was a little kicker as to why this affected me more, possibly, than I ever had before. But what's unusual is I've always had the mutation. That never changed. It was the same device. It was, so it didn't make a lot of sense why this particular time I went unconscious. But anyway, went down the rabbit hole. I got the MTHFR mutation. So now all of my vitamins are methylated. I make sure they're pre-methylated before I take them. My B12 is methylated. My multivitamin is methylated. I try not to eat as much fortified food like the breads and the pastas. I get it straight from Italy, or like Costco's got the pastas, organic, you can get straight from Italy. It doesn't have folic acid in it. So like in Europe, there'd be no problem because there's no folic acid in the grains there. But one thing that we noticed that we were trying to figure out, like maybe what happened, was that we noticed that when we turned on our nitrous unit, sometimes we heard a squeak, which told us it was sealing. And this time we didn't hear a squeak, just things that we're kind of thinking of that were unusual. And possibly I got pure nitrous. Possibly the O2 was not going through the tubing at all. That could have been a possibility too. And definitely lack of patient monitoring. I was laying on my stomach. Nobody was looking at my saturation. Nobody was watching me breathe. So literally, I was unconscious. Who knows if I was breathing or not? But if my medical assistant hadn't have alerted the providers as to my status, I would not be here right now. I owe her everything. So now what do? I always look back at things. I always look back and go, okay, how can something like this be prevented? And I don't want to point fingers at a company, a product, nothing like that. What I want to do is I want to make us all aware of monitoring that patient, because anything can happen. Anything can go wrong. So when I look back on this, I think, okay, how could I prevent this in the future? Number one, I went on Amazon and I got a continuous pulse oximeter that is battery operated, and I hear the beep of the plasmograph on their finger. So the second I put the nitrous on them, I put that pulse oximeter on their skin, and I can hear their heartbeat. Beep, 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 heartbeat, I can hear it. So I know if the heartbeat goes down or up, and it alarms if their saturation drops below 95 or 96%. That is continuous. It does not turn off. Okay, so it's like $150 on Amazon. It plugs into a charger. Perfect. So I think that's incredibly important. I also mentioned to the company, who was very, very receptive of, like, I explained to them what happened to me and how I think that it's really important that when any of these devices are sold, whoever makes them, but make sure that they require, or they tell people, you need a continuous pulse oximeter whenever somebody is on these devices, because anything can happen. Anything can happen. So monitor that patient's level of consciousness. Always have somebody watching them. If somebody's sitting up and they're getting injectables, it's easier to watch them. If somebody's laying on their stomach, this could be missed really easy. This is the first time. We've never had something where someone's laid on their stomach and we've treated them. So this is the first for us. Make sure that you have some O2 nearby, a bag valve if you have it. If you have a little crash cart in an outpatient setting, that's always really good. Take a good, thorough medical history. Make sure that if they know if they've got an MTHFR mutation, you probably would choose not to do nitrous. Not that you don't have to, but like I said, I did it several times before. I never had a problem before. And we have the same device in our clinic. The device never changed. But make sure that you inspect your devices, because there could always be a faulty device. There could always be someone with a health issue. There could be so many different issues that can cause something like this to happen. So I think it's real important to put in their chart if they do have the genetic issue. We have little sticky notes that we can put in our chart. So it's on a computer, so it pops up whenever a patient checks in, and we can see that they have don't use nitrous on this patient, or whatever it might be, whatever their little medical alert is, it pops up and we see it right away. Make sure your devices are working properly. Make sure that, like, some of them should squeak when you turn them on, and some of them maybe, I don't know, don't squeak. Whatever. Make sure that they're working properly. Make sure they get the any repairs that they need. Sometimes it's hard to know, but I would want them checked, maybe just to be certain. And the biggest thing is monitor that patient closely. If you have a medical assistant or somebody else in the room, keep all eyes on that patient. Make sure that you monitor them very closely. If it's a 50-50 mix, the patient should never be able to go unconscious. They should never be able to. I don't care how much they breathe it. If they got 50% oxygen, they should not go unconscious. So that's something, but we always need to watch for and be careful of, and just know of what can happen. Everybody's wired differently. Everybody's chemical makeup is different. And it's really, really important that we respect their physiology and monitor them. We owe this to our patients. So I think the biggest takeaway from this happening to me, and being one of the scariest things that's ever happened, I think the biggest takeaway is monitor that patient. Make sure that you've got them on a continuous pulse oximeter. Make sure you've got all eyes on that patient. Make sure you look at their breathing. Make sure that they're alert and they are nothing more than a little relaxed. Anything beyond that, take it away. Let them breathe some 21% room air for a little while, and they wake up pretty darn quickly. If something like this happens, you're going to want to institute your ABCs. Now, unfortunately, I was the only one in the room with any emergency room ICU at training, and I was one that was unconscious. So thank God everything was okay. But you make sure that their airway is clear, that they're breathing, and that their heart's beating. So you want to check for breathing. You want to check their pulse. Make sure that's all clear. If you want to put a pulse oximeter back on them, that's easy to do. That checks their saturation. That checks their pulse right away. So I think that's super, super important to understand that. ABCs, airway, breathing, circulation, super important. That's the one thing I really want you guys to take away from this, is monitoring that patient. Do we know exactly why this happened to me? No, I have my theories, but I think bottom line, monitoring that patient is the most important thing. Okay. I want to come and answer a couple questions. Let me see. So somebody asked, do you have my question's over here. Do you have a scavenging unit? No, I don't. So a lot of the outpatient units, we don't need a scavenging unit because we don't use them that long. It's not used for 2 or 3 hours. It's used for maybe 15, 20 minutes. but usually they have two tubes. One has a nitrous coming in, and then another tube is their exhale tube, and that goes down to the ground. And nitrous, like I said, is heavier than air, so it settles down deep. Now, if somebody is blowing out, if they're taking a breath of it and blowing out, yeah, the nitrous can kind of get around and you can get high with your patient. So that I wouldn't recommend, but we don't need a scavenging unit. We don't have those. I think in ORs they have them because the concentration is much higher, but that's a really good question. You're probably a CRNA. Do you feel the percentage of nitrous greatly affects the possible risk? Yes, I've had patients that only get 15% nitrous and feel more comfortable with the lower percents. Okay, I like that. My particular unit, I can't adjust, but there are some units that you can adjust the nitrous O2 mix. And if somebody feels good and kind of relaxed at 15% as opposed to 50%, go for it. I love that. I think that's terrific. Yeah. Did my provider check my B12? Yes, checked my B12, and my B12 was okay, but I do take B12 supplements anyway. But my B12 was okay, surprisingly. So I'm heterozygous, not homozygous. So I think that's probably what saved me on that. But interesting, huh? But now I take a methylated B12, and I take, like I said, methylated vitamins. So the folate is already broken down, or broken down for me. Let me see. Is genetic testing necessary, or can we identify high-risk patients without it? We cannot. We don't know if somebody's got the genetic mutation. We have no idea. I mean, we could ask them questions like, every time you eat bread, do you get bloated? And it's not like a lactate deficiency. It's something where some people that just don't metabolize well might get bloated with bread. It might not be the MTHFR. So it's something that we don't know unless we do the blood work. Now, my insurance covered my test. We did a bunch of tests, hormonal tests and everything, and my insurance covered the MTHFR. And what's interesting is now that I'm asking the question, I'm getting more patients that are coming in now telling me, oh, no, I don't, or yes, I do. More providers are checking for it now, which is interesting, right? So I think people are becoming a little bit more aware of it. Yeah. Was your device continuous flow or one you need to actively use? This is Maraza. Thank you. The device is when you have to actively use. So the one that I have is one that the patient totally controls, and I love that. And it's just that if they put it in, they take a few breaths. When they feel good, they just take it out. Let me do what I need to do. They might take a couple more breaths, take it out, do what I need to do. So it doesn't continuously flow. It's just they have to suck to open up the valve to inhale, and then they can exhale it through the tubing. So it's not continuous flow. But that's a good question. I like that. You guys have great questions. Thank you so much for asking these. Let me see. Stacy, would a patient know if they have the mutation? If they don't know, do you ask them to find out before I treat them? I do ask them if they have it. If they don't know, no, I will treat them. And like I said, I've never had a problem with a patient. The only other person I know of that had a patient that went unconscious was another nurse that I spoke with at iSpan. That the same thing happened to her patient. So I think that I ask anyway now, because if I know, then I have a heads up to not treat them. But a lot of people don't know if they have the issue. Do I still offer nitrox, it's not nitrox, but Pronox in my practice after this? I do. Yeah, I do. Am I more careful about monitoring my patients? Absolutely. Absolutely. The saturation monitor goes on their finger before they even look at the Pronox, but the machine I have. So that saturation monitor goes on their finger because it's really, really important that I monitor them. And like I said, I've never had a problem. I watch them like a hawk. My medical assistant watches them like a hawk. And most of the patients are sitting up and I'm talking to them, or they're laying down and I'm looking at their face. So it's something that I can see them. I can look at their level of consciousness. I can watch their eyes look at me. They can talk to me. So I'm making sure that I have that alertness level, that level of consciousness that we're maintaining. And their voice lowers a little bit. They just feel more relaxed, and I can hear that. I can hear the nitrous is taking effect. So we just keep them there, and they give it to themselves. You know what I've noticed is most patients don't inhale it enough. Like some, you can't get it out of their mouth. Okay, some of them are just like this, and even when you're done, they're breathing it because they love the way it feels. There's some that you can't get out of their hands. Most of them actually, it's like take a few breaths, they get relaxed, and then they just stop. They let you do everything. And I have to remind them, Are you okay? Do you want some more breaths? They're like, oh, okay. So many people don't even remember to take more breaths, but it goes away so quickly. Within 5 to 8 minutes, they're totally back to normal. They can drive home. So I warn my patients that it goes away so quickly that you have to remember to kind of top it off and take a breath here and there as I'm doing the procedure, be it like a CO2 or a procedure that's more uncomfortable. Keep topping it off. Don't let it all go away while I'm doing this procedure, because sometimes they're a little bit more conservative and don't use it enough, which is interesting. Let me see. What would be given for someone with this mutation moving forward? Oh, that's such a good question. I wouldn't give them nitrous. I would just make sure they're numbed nice with lidocaine and not offer it. And if you don't offer it, they don't know you have it. So if patients have had it before, then they know you have it, and they know how nice it is to have. It's so nice to be relaxed and just feel less anxious. But if I don't offer it, then they don't even know I have it. So there's my trick right there. Let me see. Does your practice allow medical assistants or estheticians to administer Pronox? Absolutely not. If they've got to sign a consent for it, it's a medication that I have to prescribe, basically. So no, we don't let MAs or estheticians administer it. And I'm really glad. I'm really glad now that I can see what can happen. No, I think we need a medical professional in the office. My medical assistant is absolutely beautiful, eyes on the scene, something to alert me if she or he would see something. So I think it's really important. But I think it's important that we as medical providers understand the risks and benefits. We can give an informed consent, and we can monitor them accordingly to what this drug can do, what this gas can do. Let me see. Let me see another one. Let me see. Does your practice? Let me see. Oh, just a good question. Check COPD and okay. Oh, good question. Check for COPD, right? So if they are a pink puffer or a blue bloater and they have CO2 retaining, or if they have an issue, check and ask them, and you'd be more aware of maybe not giving them the nitrous or really monitoring them closely. Thank you so much. That's such a good suggestion. And I see the symptoms went away in about 5 minutes, but I'd be a little scared if my patients started hallucinating too. Interesting. Is it the same as use? No, it's a different nitrous than in race cars, but thanks for asking. Let me see. I would have also thought this was a mild, moderate presentation of last in the differential because of the tumescent. Interesting. Okay, so you're thinking that it might have been like a lidocaine toxicity, but in the tumescent, it's done per kilogram, lidocaine per kilogram. And I did look at that, and my dose per kilogram of lidocaine was so low. It was like a quarter of what the normal patient gets during this procedure, because I don't do a lot of tumescent. And that wasn't it. It was such a low amount of lidocaine that I got that it wasn't in the differential as far as a little bit of lidocaine toxicity. And if it was, I'd be looking for bradycardia. I'd be looking for, and I wouldn't have bounced back as quickly as I bounced back. Within like 30 seconds, I was much more awake. So, but that's a good thing to think about. And that's something that we have had people die with BLT. We have had people die with lidocaine toxicity because providers don't understand lidocaine can kill you. You go bradycardic and you don't get out of it unless you have an AED or something. You probably still can't even get out of it unless you have atropine. But it can be really dangerous too. So I think assessing that's a good suggestion. Like when you've got somebody and you're doing tumescent and they might have a little too much lidocaine on board, or it might have been mixed by somebody else. I always mix my own, but that can always be a possibility. That's a really good point to bring up. Would you avoid giving patients to nitrous to any patient who self-reports being low on B12? That's interesting too. So there can be other issues with B12. Like you can have a malabsorption syndrome you can have a gastric bypass, you can have malabsorption syndrome or lack of intrinsic factor in your gut, and you could have a low B12. So there's other issues that could cause a low B12. So I wouldn't not give them nitrous, but I would probably ask them to be checked or maybe have a genetic screening for it. But that's a good point too. Yeah, that could be one reason for a low B12. Yeah. Any other questions, you guys? You guys have had great questions. Thank you so much. So, so that's what kind of happened to me. And I wanted to share that with you guys. And again, It's not a device. I am not slamming a device. I am just saying that we need to really monitor that patient. We need to be aware of, like, anything can happen. We use a needle to inject, or a cannula to inject fillers, and you can have a vascular occlusion. You can have a vascular adverse event. You can have problems. So I want you to be very aware and cognizant of keeping your eyes on that patient and making sure that they are safe. And number one, I think, is getting a rechargeable pulse oximeter that's continuous, and you put it on them and you're listening to that the whole time. You're listening to their pulse and you're listening for it to alarm if anything drops, and you're keeping your eyes on that patient. No matter what device you're using, any device can have a problem. I don't care what the companies say. It's not the device, it's us using it, and it's us monitoring our patient and making sure that they are safe. So I think that's the biggest and most important takeaway from me sharing this scary thing that happened to me with you that I'll never forget. But it made me realize the importance of how we need to take care of our patients and monitor our patients. So if we don't have any other questions, if there's no other questions, I'm going to kind of, let me see. Oh, which pulse ox? A question. I got off Amazon. So I can share it with the team, with the Aesthetic Immersion team, if you want it. Maybe email them, or I can pull it up and somehow they can send it to you. But it was about $150, $160. It has a little white holder and it slides right into the holder, and it's a plasmograph. It's got the pulse and it's got the saturation, and it alarms, and it plugs in and it just stays recharged. So I can pull the whole thing out. It's cordless, and I can put it on the patient's tummy, put their finger on it, and monitor them. So it doesn't have to be a certain brand, but I can, if you email us, I can have the team send you a picture of maybe the one I bought a while back if I can find it. But I just got off Amazon. It works beautifully. Good question. Thank you. All right. So if there's no other questions, I'm gonna kind of close out. Thank you so much for joining. I appreciate it, you guys. Just sharing a little bit of myself with you, and I hope it makes you a little bit more aware of our patient monitoring and how we use different things like nitrous and things in our office, and lidocaine. Different things can have side effect. Even BLT can be a problem. So we need to really monitor our patients carefully. Thank you so much. I wanted to let you know too, also, a couple things coming up. So on our next AI Live, which is February 3rd, 5 p.m., we have menopause and aesthetics. This is Dr. Salmons, who is a brilliant doctor, OB by education, but she is into the functional medicine very strongly. Brilliant doctor. She is mine. I love her. She's great. Brilliant lady. She is going to be talking about menopause and aesthetics. She also has done, that's going to be February 3rd. She is also going to be doing a Master the Mix IV therapy course. You can purchase that now. This is one that teaches you all about mastering the mix of IV therapies, what to use, what works, for when, and how to be safe using those. And that picture is of Dr. Jackie Salmons. And then we are also going to have Beyond Occlusions. It's 4.5 hours of amazing content that we are talking about everything beyond occlusions. We talk about adverse events. We talk about fillers, lasers, threads, radiofrequency microneedling, all different types of issues that we want to look at the adverse events of, be able to assess them, and be able to treat them. So Beyond Occlusions is going to be coming, and that is on replay. That's about 4.5 hours of content. That's going to be really, really good for you to see and watch. So this AI Live is going to be on YouTube within a couple weeks, and you can pick it up then, and it's available on our podcast and on our website, and everything's going to be there for you to see later on if you missed this. So we thank you so much for joining us. We appreciate it. Thank you so much, and thanks for helping me be with somebody while my other partner is gone. So appreciate you guys. We'll see you next AI Live.